and I do want to integrate case studies pretty frequently into the show. And so today I'm going to start off with something that's very simple. And I want to just work up a patient for hypertension and kind of walk through those. If you're earlier in your program, if you're just starting clinicals, something as simple as this is extremely helpful just to hear it talked out, and when you're considering what kind of diagnostics you should be considering other than, oh, this is just plain old hypertension, what kind of differentials and red flags that you should be looking for. So let's start off with Mr. Smith, who is a 45-year-old male who presents to the clinic with a complaint of high blood pressure. He has no significant past medical history and does not take any medications regularly. He leads a sedentary lifestyle, has a high-stress job, and a family history of hypertension. To assess Mr. Smith's hypertension and evaluate potential underlying causes, the following diagnostics should be ordered. We should, of course, we want to get a blood pressure, and we want it to be accurate and an accurate reading. And something to consider is, was it taken as soon as they came in? Have they had a chance to sit down? When I worked in cardiology, one of the main pieces of advice for taking blood pressure was that the patient needed to be sitting down for 5 minutes. Their legs cannot be crossed, because if their legs are crossed, they're going to increase the pressure above that crossing point instead of the whole circulatory system. The blood flowing through the whole circulatory system, it's being cut off at a point, and so you can have a false hypertension. With that, you also probably want to get a reading yourself if your MA or nurse took the blood pressure. Getting a second blood pressure is important, and we don't want to really confirm hypertension on a automatic blood pressure cuff. We really want to make sure that we're diagnosing hypertension based off of a manual reading, and again, we want to do that at 2 separate visits too. And so 2 ways to kind of get around that. If someone is presenting with hypertension for the first time, we can look back at their chart if we have access to previous chart history, and there seems to be a continuous history of, oh, he was at this urgent care clinic, he was in the hospital, like this, that, and the other. You can kind of go back and see if he's had a trend of hypertension that was not related to either, pain or being on cold medicine, things like that. Look for that pattern, see if it's already there. If you know that pattern is there, then you need to get him in for maybe a nurse visit within the next week to recheck the blood pressure, or come back in, or do blood pressure readings at home, do an ambulatory blood pressure monitor, which are kind of hit or miss as far as accuracy. But those are some things that we can do. We want to check a lipid profile, fasting plasma glucose, urinalysis, and an EKG. All of those things could result in findings that could be leading to the hypertension or could be making the hypertension worse. So again, that's a lipid profile, a fasting plasma glucose, a urinalysis, and an EKG. So with the lipid profile, of course, if we're looking at elevated cholesterol, that can contribute to hypertension. A fasting plasma glucose, if we want to see if there's diabetes, because that's a confounding risk factor. Urinalysis, you're wanting to see how long has this patient been hypertensive. If there's proteinuria or hematuria, that means we already have organ involvement, and this could be hypertension that's been going on for quite a while. And then that EKG, we want to look for left ventricular hypertrophy, dysrhythmias. Again, those can also contribute to hypertension. When you're considering your differentials, a lot of your patients are going to have essential hypertension, which is the most common form. It's got no identifiable cause. It could be related to lifestyle factors. It could be overweight, high salt diet, sedentary lifestyle, genetic predisposition. There are tons of people who have familial hypertension where it's just going down generations. Personally, my family is this way. I have several people in my family where it seems to just kind of be passing down from person to person with decent lifestyle habits. And I've got plenty of patients that have come in, they're just depressed and super upset that they're getting these hypertensive readings, and they're runners, or they're very healthy, vegetarians, different things like that, who come in with hypertension, and they're very upset that their healthy lifestyle has resulted in hypertension. And there is a genetic predisposition. So those are the patients, when we really evaluate the lifestyle, we really evaluate, make sure there's no secondary causes, that it's a genetic thing. You look back at the family history, several generations have had it. Okay, we have to treat it. Secondary hypertension, which I just mentioned, this can be caused by another underlying medical condition. So you're looking at a patient, they don't match the standard risk factors for hypertension. You want to look at some of these secondary causes, such as a kidney disease, endocrine disease like hyperthyroidism, because with hyperthyroidism, everything's high, elevated heart rate, elevated blood pressure. Cushing's syndrome, because that one is an excess of the 3 S's, and so that would be excess sodium retention, water retention, hypertension. Or some medications, chronic NSAID use, oral contraceptives, excess illicit things, of course, excess caffeine, things like that could all contribute to a secondary hypertension. Another differential when you're working up a new patient with hypertension is white coat hypertension, which to me, this one is kind of difficult for me to get on board with sometimes. Some individuals do experience elevated blood pressure only in a clinical setting due to anxiety or stress. I get concerned when someone says they have white coat hypertension. It's not something that I just believe right away. I would prefer to have a home blood pressure log or an ambulatory blood pressure monitor to kind of rule that out. I would leave the white coat hypertension off the table until I've really ruled out the home blood pressures need to be good before I would, again, get on board with that. Masked hypertension, this is kind of a flip side. So the patient may come in with the symptoms of hypertension or home readings of hypertension, and they come in and they don't have it when they're in the clinical setting. This, again, is called masked hypertension. I recently read another case study on this just like 2 or 3 days ago, and that was very interesting. So this, again, should be detected with an ambulatory blood pressure cuff or a home blood pressure log. We do like the ambulatory blood pressure monitoring system because it's ours, but you can work that up. So based on the initial evaluation, so let's say Mr. Smith is diagnosed with essential hypertension. We see him on 2 separate occasions. We do diagnose that he has hypertension. What kind of treatment, follow-up plan, and education are we going to provide for this patient? So lifestyle modifications are going to be number 1 because he had a poor diet and sedentary lifestyle. So we need to introduce regular exercise. And I'm a very big fan of the stepwise approach and really small manageable things, because if you tell a patient with hypertension they have to fix 5 things tomorrow, it's not going to happen unless they're the type of person that's seriously motivated and really wants to get a hold on it. So I would say let's do small things. Let's try exercising once or twice a week with a goal of maybe 3 to 4 times a week. Let's start with losing 2 pounds instead of you need to lose 50 pounds, Mr. Smith. That is a huge goal, and it takes, if you look at the average amount of weight that a person can lose in a week, it's like half a pound to a pound. So to tell someone that they need to lose 50 pounds, that can be a very long time commitment, and they're going to get discouraged when that doesn't happen very quickly for them. So we need to encourage, let's start with setting a goal of 6 weeks of regular exercise. Let's see if you can drop 3 to 6 pounds, and see how, also adopting that heart healthy diet using a DASH kind of approach, low sodium intake, avoid excessive alcohol consumption, and then medication as well. So if he we can sometimes start with lifestyle modifications. Let's say he's at 160/90, already maybe has a little proteinuria. We're going to want to go ahead and do medications. ACE and ARB is a good bet, especially if we're wanting some renal protection, say he had a little proteinuria. Calcium channel blockers and thiazide diuretics. So if he had any swelling, I would also maybe start him on a low dose of diuretics. Again, the choice of medication is specific to provider and patient. It's a twofold approach. There are people who will kind of have a standard approach to blood pressure and they do it the same way every single time. And when you look at the JNC8 guidelines, there's several different pathways that one can take through the JNC8 guidelines. It's down there at the bottom if you pull the PDF form of it, A, B, and C, about how to approach it, because it does, again, say you can start any of these medications. Working in cardiology, as a nurse, I watched the 17 physicians I was working with do very similar things over and over again. And that was helpful for me to kind of form my pathways, as seems to be the most appropriate approach. They would typically start with an ACE like lisinopril at 10 or 20, 40, or 10, 20, or 40 milligrams, 10 or 20 being more common. Letting that, see if it works. If that does not work, you can increase the dose. If that does not work, you add hydrochlorothiazide. And I did see that being done many times. It kind of took them a while to get to the calcium channel blocker. It is a good medication. It's perfectly fine, but this was just the patterns that I was seeing. And so I found myself doing that. My own practice was one try with lisinopril, increase the dose, and then add an HCTZ. So find something, stick your name in it, and say that's how I'm going to approach blood pressure, unless the patient presents to me with some extenuating factor or circumstance that makes me want to pick one of these other medications more quickly. Why do we pick ACEs first? They do work a little bit better. Why would we switch to an ARB if a patient has the cough or any of the other side effects that you see with the ACE inhibitor? What other kind of things are we going to do for Mr. Smith? We are going to do regular blood pressure monitoring. So you or your nurse needs to teach Mr. Smith how to take his blood pressure at home properly, making sure he understands he needs to sit down for 5 minutes with his feet flat, not doing anything stressful, and then take his blood pressure. The time of day matters when we're doing blood pressure logs. There's kind of a minimum effort and a maximum effort, and anything is fine as long as we're hitting that minimum effort. It is very, very helpful to have a blood pressure reading 3 hours after they take their medication. Most of those blood pressure medications peak in effectiveness about 3 hours after you take them. So we want to see, is the medicine that we're taking actually working for our patient? So taking that blood pressure 3 hours after is a good rule. So to have them do that, they need to take their blood pressure cuff with them to work. That's fine. To make sure they can keep their log. Ideally, if the patient wants to, and a lot of patients with hypertension really do want to follow it, and they really are really interested in taking several readings per day. A morning one, right when they wake up, 1 3 hours after the medication, and one in the evening. That is helpful. That is helpful. We want at least one blood pressure reading per day, but if they give us all of those, that's great. Encourage them to write down the date, the time, their blood pressure, and their heart rate, and any extenuating circumstances. Say that they had been in pain from something or had accidentally taken a cold medication that had Sudafed in it. Something like that, they can have that in there. A lot of clinics have invested a little bit of time in creating a blood pressure log to give to their patients because everybody knows that executive dysfunction is real, and starting something is hard if you also have to figure out how to make the log or what you're going to do there. So giving the patient a log to go ahead and fill out can also be helpful and kind of take away one barrier for them to start. Follow-up visits. We are going to do regular follow-up visits. You're going to want to see the patient back in 2 to 4 weeks following the initiation of medications. You're also going to want to get lab work. A lot of these medications can kind of mess with electrolytes. Yeah, you can look into those further. I'm not going to take the time to go into which medications cause which electrolyte problems, just for time here. But you want to make sure you're getting an electrolyte panel. Well, again, how are we going to educate him? Some of these things have already been mentioned. Awareness of what can happen if we let this remain uncontrolled. Sometimes patients don't quite grasp what the big deal is about hypertension, and we would want to educate with specifics about when blood pressure is really high, it starts to create a lot of tension and damage on the organs that the blood is feeding, right? So you've got this whole system all over your body. It's being fed by all these vessels and systems, and if the heart is pushing too hard, if the blood pressure is too high, the heart is going to get damaged and run out because it's trying too hard and working too hard. If you're putting a lot of pressure onto your head and your brain, you're looking at a stroke. So trying to put it in terms that the patient would understand, things that are relatable, will help them understand the significance of treating hypertension well. Lifestyle modifications are some of the hardest parts because people are really stuck in their patterns. Like I said, small increments, small goals about how many times you're going to exercise or how much weight you're going to lose. Smoking cessation, I'm a big fan of cold turkey there. So that's one place where I would probably encourage, this is something that we could stop tomorrow and it's going to make a huge change. Of course, you can offer medications to help with the smoking cessation. You can do one of the step patch programs. You can do some of the oral medications that help decrease desire to smoke as long as they don't have any of the risk factors, because there are a good number of risk factors and reasons why you can't prescribe things like Wellbutrin or Chantix. And stress reduction, which can be difficult, but hopefully we can help them. We can send them either to therapy if they want to look at some ways to have a hobby or try to balance their stress, or consider if there is options for a different work choice, like say they don't have to be at the job they are and there are other things available for them. Maybe they do need to switch it up because it is harming their body. Medication compliance, making sure they understand time of day that they're supposed to take it, and any other things that are important about taking the medication. Side effects, making sure they're taking it same time every day. Can't take it willy-nilly. Often we do not really recommend for patients to double up on a dose if they miss one. Again, teaching them how to do the blood pressure monitoring. What's their target goal? Like what do we want blood pressure to be? Let's not just tell them they have hypertension and send them on their way. Let's tell them this is where it is, this is where we would like for it to be. And make sure that they understand the importance of following up with their provider. And if we need to end up referring them out to cardiology or nephrology because there's end organ damage going on, or signs and symptoms of other cardiovascular involvement. Hypertension alone really should be managed by the primary care provider, and you are that. And if there's hypertension alone and they're not resistant to medications, there is no reason to send them to cardiology unless you're seeing, again, you have to see some signs of other involvement going on before you want to send them over to cardiology. And so what are we going to do? This is it. That's what we're going to do for this patient. We're implementing these measures. We're hoping he can actively participate in the management of his hypertension and improve his overall cardiovascular health. And so that wraps up an approach to hypertension. I hope you enjoyed this. Make sure you like, subscribe, and share this with your classmates if this was helpful. Comment what you want to see in the next case study. Bye.